So I do not have any conflict of interest to disclose. Just to make sure that everybody's awake, can I ask you to join through this vvox.app? Just type vvox.app on the Google browser, and then there is an ID 127055675. So we will be connected. I'll try my best to adhere with the time. Okay, so the ID is still on the top. You can keep joining. And this scenario, 52-year female with a previous diagnosis of MASH has been admitted to the hospital with increased abdominal girth. She additionally is found to be thrombocytopenic with platelets of 72 and INR of 2.2. The ultrasound shows coarse liver texture. Her liver enzymes are ALT 750, AST 600, elevated IgG. The diagnostic paracentesis shows a serum acidic gradient of 1.5, proteins 1.9. Echo is normal, so she's scheduled for a transjugular biopsy, and you have been asked to comment on her bleeding risk. So you can click on the answer if you see the questions. So should we transfuse FFPs? Should we transfuse platelets? Do nothing? Good. Great to see the response. Right, so patients with cirrhosis have long been considered to have a high risk of bleeding. And this is because we see the abnormal standard coagulation test, prolonged INR, low platelets, low fibrinogen. And there is more frequent bleeding episodes in patients with liver disease, which could be portal hypertension related or non-portal hypertensive. And although there is evidence emerging in past 2 decades that has debunked this myth. So abnormal standard coagulation profile shows only one face of the coin. These variables cannot provide a global assessment of hemostasis. Liver also produce anticoagulant molecules like protein C, S, and antithrombin 3. And low platelets could be because of the splenic sequestration or low thrombomodulin leading to decreased production. But there is a rebalance with increased level of activation, increase in von Willebrand factor, decrease in ADAM-TS13, and portal hypertension-induced endotoxemia. So there are higher rates of bleeding events in patients with cirrhosis. Portal hypertension-related bleeding is likely because of the increased intravascular pressure exceeding the elastic properties of the vessels, and it's not related with the coagulation. And there may be some concurrent risk factors like frailty leading to trauma and bruisability, and these patients often require more interventions like biopsies, TIPS, paracentesis. So we know that there are anti-hemostatic mechanisms in liver patients. There's thrombocytopenia, reduction in procoagulant factors, increased TPA, but there is also pro-hemostatic mechanism going on with increased von Willebrand, ADAM-TS, increased factor 8, reduced production of anticoagulants. So there is a fine balance which is unstable in this population. So coming towards the paracentesis, which is the most frequent clinical dilemma, thrombocytopenia does not demonstrate an increased risk of bleeding in minimally invasive procedures like paracentesis and thoracocentesis, although low fibrinogen level can be associated with slight elevated risk of bleeding after paracentesis. So using a cutoff of less than 60, the fibrinogen was more accurately predicting the risk of bleeding with the AUC of 0.749 with the odd risk of 11.1. And in this study of 433 patients with ACLF, they compared 18 bleeding events with 584 non-bleeding events, and the propensity score matching was done. And you can see lower fibrinogen level was independently predicting the hemorrhagic complications. With a cutoff value of 0.7, it was pretty sensitive and specific to determine the risk of bleeding. And the another thing is AKI. It's linked with increased bleeding risk during the procedures like paracentesis. This retrospective chart review done from 2012 to 2016, patients with post-paracentesis hemoperitoneum confirmed on CT scan were compared with patients during the same period of admission with suspected bleed, but it was ruled out on CT scan. And multivariate analysis showed that AKI prior to paracentesis was the independent predictor of post-paracentesis hemoperitoneum. And this was independent of the null score, volume of paracentesis, sepsis, platelets, INR, or hemoglobin level. And we also need to look into distinct clinical context, whether the patient is stable or unstable. Like it's been shown that there was no post-paracentesis bleeding in patients who have stable liver disease, despite abnormal coagulation profile like platelets more than 50 and INR around 1.7. However, there was 3% post-paracentesis bleeding in patients who had ACLF with same coagulation profile. Now, liver biopsy is a common procedure in liver patients with a bleeding event around 1 to 6 per 1,000 biopsies. Systemic ultrasound, if you do, you can actually find more hematoma or peritoneal bleeding up to 23% of the patients. The standard coagulation tests do not predict the post-procedure bleeding in cirrhotic patients, and the previous established thresholds are failed to differentiate between procedure-related bleeding versus not. And this prospective multi-center observational study, 380 patients were categorized as group A, which is INR more than 1.5 and platelets less than 50, versus group B, which is normal INR and platelets or more than 50. And then they were categorized into low risk and high risk procedures. And you can see that there was no significant difference in these patients in terms of bleeding for low or high risk and INR or platelets. And this retrospective analysis of around 1,800 liver biopsies, which were done from 2004 to 2009, as per the SIR guidelines, INR was kept less than 1.5 and platelets more than 50. And then the center changed the policy and went to a less stringent guidelines from 2009 onwards, with INR up to 2 and platelets up to 25. And there was no increased risk of bleeding. In fact, there was significantly reduced blood product transfusion. And it appears that the predictive probability of any bleeding complication was more related with INR rather than the platelets. Hall C trial is the largest cohort of patients with advanced liver disease undergoing percutaneous liver biopsy. The overall hemorrhagic rate was only around 0.6%, although it was slightly higher for patients with platelets less than 60. Thrombopoietin receptor agonist can be considered on case-to-case basis in patients who require liver biopsy, starting 1 or 2 weeks before to increase the platelet count if it is less than 50. So currently, EASL does not recommend routine assessment of hemostatic parameters in cirrhotic patients undergoing liver biopsy. Now, the percutaneous tumor ablation like RFA and microwave, in clinical practice, these procedures are seldom carried out in individuals with platelet count less than 50, and majority of time these patients are already transfused, so there is no clear data about this population. However, it appears that potentially platelets less than 50 have an increased risk of post-procedure bleeding, and there is no definite cutoff or optimal target of the platelets to be achieved before these procedures. The Cardiovascular and Interventional Radiology Society of Europe recommends that INR should be kept around below 2.5 in liver patients, platelets of around 30, and fibrinogen level of around 100. So these are the recommendations. Now, coming towards variceal bleeding and endoscopic therapy, it is like majority of the times patients coming with cirrhosis and portal hypertension have variceal bleed as a cause, but it is not associated with the hemostatic dysfunction. It is directly correlated with the severity of portal hypertension and local vascular irregularities. So hepatic venous pressure gradient determines the risk of developing varices, risk of bleeding, and the risk of failure to successfully control the bleeding. So variceal bleeding is considered as a high-risk invasive procedure with a bleeding risk of around 2.7 to 7.3%. Most of the bleeding episodes occur late after the procedure, and as I mentioned, it's not because of the platelets and INR, but it's because of the lack of control of decompensating event or portal hypertension, or maybe because of the mechanical injury caused by the bends, like post-bending ulcers. There's only one relatively small study which was retrospective in nature and mentioned that low fibrinogen level can be associated with rebleeding after banding. But nonetheless, these patients receive unwarranted blood products like FFPs, platelets, and red cells as a reflex action when you see the patient bleeding. So this is a meta-analysis confirming that abnormalities in platelets and INR do not correlate with the peri-procedural bleeding events among patients with cirrhosis. And in fact, patients who receive FFPs had a high risk of mortality and failure to control bleed and length of stay as compared to the patients who did not receive FFPs. And also these patients who receive FFP transfusion, they were at higher risk of multi-organ failure like liver, kidney, coagulation, and respiratory failure, etc. Now, coming towards the thrombocytopenia, in this analysis of around 2,200 patients, where cirrhotic patients with variceal bleed who required platelets transfusion versus who did not, they were propensity matched with age, pulse rate, creatinine, presence of ascites, and cephalopathy, and it appears that the rebleeding rate was, 5-day rebleeding rate was 14.6% versus 4.5%, so significantly low in patients who were not transfused. So the patients who received transfused had actually higher rate of rebleeding, and the baseline thrombocytopenia did not influence the rebleeding and mortality. Now, coming towards the elective band ligation, this study was comprised of around 1,400 procedures on 500 patients. And you can see the risk of bleeding was only 2.7% in patients with INR more than 1.5, and the risk of bleeding was only 7% in patients with platelets less than 50. And there was no significant difference in patients who were transfused or not transfused. In fact, MELD was the only factor which determines on multivariate analysis of the risk of bleeding after band ligation. Coming towards colonoscopy, diagnostic colonoscopy is pretty safe with bleeding rare up to like 0.03% only, and it can happen after biopsy if you biopsy the vascular structure or especially in patients with impaired blood coagulation, or maybe because of the mechanical trauma by the endoscope. However, polypectomy can lead to bleeding, which is the most common complication, up to 0.3 to 6.1%, depending on the multiple factors like size of the polyp, whether it is pedunculated or sessile. In liver patients, the advanced liver disease like child B and C was significantly associated with post-polypectomy bleeding as compared to child A and as compared to non-cirrhotic patients. And on multivariate analysis, child B, C cirrhosis, platelet less than 50, 3 or more polyps, EMR or ESD, and polypectomy performed by the trainees were associated with immediate post-polypectomy bleeding, while advanced liver disease and the polyp size of more than 1 centimeter were associated with delayed bleeding. Now, advanced endoscopic procedures like EMR and ESD, this was the meta-analysis of 10 studies comprising of 3,200 patients. The pool rate of immediate bleeding was 9.5%, and pool rate of delayed bleeding was 6.6%. And the risk factors associated with post-EMR bleeding include age more than 65, antiplatelet use within last 5 days, right side polyp, and lesion diameter more than 15 mm. For ERCP, the bleeding rate is around 1.3%, and it could be because of mechanical trauma, sphincterotomy, sphincteroplasty, biopsy, In cirrhosis, it's because of portal hypertension causing fragile blood vessels in the mucosa and submucosa, mucosal fragility and susceptibility to trauma, thrombocytopenia. These patients may have congestive duodenopathy and coagulopathy. So this is again a match analysis of around 36,000 ERCPs in which 1:4 cirrhotic versus non-cirrhotic was age matched. And you can see that cirrhotic patients had higher risk of ERCP-associated hemorrhage, twice as common to the non-cirrhotic patients. And presence of cirrhosis along with Alex-Hoxer's index, therapeutic interventions, biliary sphincterotomy were associated with increased risk, while procedures performed in high volume center were associated with decreased risk of bleeding. So currently ESGE guidelines recommend platelets less than 50 for patients going for ERCP with the increased risk of bleeding if it is less than this, around 35 folds. However, there is no correlation with INR and the occurrence of post-ERCP bleeding. Interestingly, these patients may have esophageal or gastric variceal bleeding, gastric varices, but the bleeding is negligible. Now, coming towards a tailored approach, as we discussed historically, bleeding complications were frequently attributed to the alteration of hemostatic profiles such as INR and low platelets, but now we are changing the approach how we address the prophylactic hemostatic intervention. So for prevention of bleeding, we need to assess the risk of bleeding, take a detailed medical history. There should be a clear rationale for the procedure. Laboratory tests like INR and APTT, although they lack predictive value. Platelets count, there is no reliable safe threshold. Look for the potentially modifiable risk factors like anticoagulation or antiplatelet use, kidney injury, sepsis. According to EASL and AASLD, they are classified, the procedures are classified into low risk and high risk. If it is less than 1.5%, it is low risk. They are in the green. Those in the red are the high risk procedures like biopsies and dental extraction, TIPS, polypectomy, ERCP, EUS biopsies. Those in the orange are like conflicted. AASLD says they are high risk, EASL says they are low risk. So based on the recent EASL guidelines, there is no recommendation for use of INR, platelets, fibrinogen, or elastometry for these patients going for procedures. And in terms of transfusion, it is only done on case-to-case basis if the platelets are less than 20 or between 20 to 50. And if it is more than 50, then they are not recommended. Now, the bleeding happened in three aspects. One, the bleeding is related to the portal hypertension itself, like variceal bleeding, and it is independent of the hemostatic failure. Second, the bleeding can be because of the mechanical vessel injury, and it is again not related with the hemostatic failure. And then spontaneous or unprovoked bleeding like bruises or mucosal oozing, which is linked with the hemostatic failure, but it is challenging to predict. So if there is a variceal bleeding, correct the hemostatic abnormalities is not indicated if hemostasis can be achieved by the portal hypertension lowering drugs like terlipressin and octreotide and endoscopic treatment like band ligation. Administration of blood products may actually increase the portal pressure and that worsen the outcome. So a restrictive red cell transfusion strategy would be beneficial, and large volume of blood products may increase the bleeding. For the bleeding which is related to portal hypertension but not variceal, there is no data comparing the efficacy, so the guidelines are silent in this. The recommendation is manage the bleeding with portal hypertensive measures and consider correcting the hemostasis on case-to-case basis. For non-portal hypertension causes, address the active bleeding with local measures or IR intervention, and then address the contributing factors like renal failure, sepsis, anemia. Consider the correction of hemostatic abnormalities on case-to-case basis, and antifibrinolytic agent like tranexamic acids are discouraged. Now, how to assess the coagulation in these patients because of the delicate equilibrium between procoagulant and anticoagulant factors? There is no right answer. As we mentioned, thrombocytopenia is multifactorial, and there is a compensatory hyperactivation. So the shifts contribute to the state of unstable counterbalancing where both hypo and hypercoagulable tendencies coexist. Now, there may be inaccurate platelet measurements because of multiple factors like delayed blood processing in the lab, inappropriate anticoagulant use, citrate-induced dilution effects, technical factors, and also the drugs like beta blockers can affect the platelet aggregation, and hyperbilirubinemia can impair the platelet energy metabolism and function. So there are more in-depth assessment of platelet activation by aggregometry, flow cytometry, and microfluidic system which can be used. For coagulation, again, INR may not be a true reflection. So thrombin generation test can be used. And then viscoelastic tests are a better modality to reflect the accurate reflection of the coagulation status. And they can guide the transfusion therapy by identifying deficiencies in the fibrinogen or platelets, and they can reduce the blood product transfusion, especially before intervention procedures. And it's been shown that even during the liver transplantation, there was reduction in use of FFPs if the transfusion was guided by the thromboelastography. And same here in the liver patients who are undergoing a high-risk procedure, there was reduction in the transfusion of FFPs or platelets if the transfusion was guided by thromboelastography. So this is to summarize, rebleeding, hemostasis, rebalance hemostasis between procoagulant and anticoagulant, identify the risk factors like portal hypertension, AKI, anemia, drugs, sepsis, and there is no prophylactic transfusion for the procedures. And the case-to-case basis risk mitigation should be done, judicious use of indication, and then once there is bleeding, then try to control the bleeding by correcting the underlying cause, portal hypertension correction, correct the anemia, and then transfusion of platelets and INR on case-to-case basis. So coming back to the case, let's see if we can have the right answer. So to start with, 70% of the group agrees that her thrombocytopenia and INR do not need to be corrected to prevent post-bleeding, post-biopsy bleeding, and I hope I'm able to clear for the rest of the 25%. Thank you very much.
Thank you.